we'll be going through pediatric emergency radiology. The presenter, Glenda, and Dr. Manga will be the facilitator. So we'll go through CNS infections, we'll go through the meningitis, cerebritis, cerebral abscess. We'll also go through neonatal germinal matrix hemorrhage, AVM, moya, and coagulation disorders, perinatal brain injury, sickle cell disease, and imaging the child with seizures. So we'll start with meningitis, which is the inflammation of meninges of the brain. In newborns, it is acquired from infection of the bloodstream. The most common infection is via the birth canal, which is through group B streptococci, E. coli, and listeria. In older infants and children, it's mostly through respiratory secretions, which now will cause a meningitis, and these are caused by strep pneumo and Neisseria meningitidis. For a long time, Haemophilus influenza type B was one of the most common causes of meningitis, but since vaccination became widespread, we've been seeing fewer cases of meningitis caused by HIV. So the clinical presentation in the pediatric population, you have a patient that a baby in coma or with inability to drink or feed. AVPU will be at pain or unresponsive. The patient will have a stiff neck, bulging fontanelles may be present. You might have fits if the child is less than 6 or more than 6 years, less than 6 months or more than 6 years. There will be evidence of partial seizures. The baby might be agitated, and there could be convulsions as well. The complications for this illness, you can have communicating hydrocephalus, you can have subdural and epidural empyema. You can have cerebritis and cerebral abscess, infarction, ventriculitis, and dural sinus thrombosis. Some of the complications are topics within themselves, so we'll go through them in the upcoming slides. So meningitis on sonography will appear as thickening of meninges or widening of the sulci, which is a common early sign. Complications, as we had said, subdural and empyemas or fluid collections. You can have cerebritis as well, abscess formation, and venous sinus thrombosis. In fact, infections can occur from either arterial vasculitis or venous obstruction as a result of venous sinus thrombosis. Sonography is not. It can identify the complications, but it is not specific to the meningitis. Yeah. So we'll go to a couple of sonograms. Here we have two, one in coronal and a sagittal section, and one in A. We have a coronal section, and we've got my laser pointer on, and we're seeing diffusely echogenic sulci that appear thicker than normal. So you have the sulci here becoming echogenic, that is bilaterally, and they appear thicker than what you expect in a normal patient, and it's better visualized here on the sagittal section, where you have the sulci being very echogenic, and they are thicker and not very well defined.
So why do they have that appearance?
Because of the infection of the meninges, so you have increased products of inflammation.
So the meninges are thickened. The CSF could be purulent. Sometimes there may be echogenicities in the CSF. If there's ventriculitis, again, you'd even see the pendymal lining is thickened, and you can also see echogenicities within the CSF fluid. So all those combination of factors create that, yeah. Okay.
So here we have sonograms of different patients. No, here we have a coronal Doppler sonogram of a baby. This is in coronal section, and here we're looking at the MCA, which the arrow is pointing at an infarction, which can be which meningitis can lead to an infarction. Here there was an infarction of the MCA, which just showed as an symmetrical increased echogenicity in the grayscale Doppler.
So what you want to say is that there's a thrombus in the MCA, or there's no flow.
Yeah.
Yeah,
or there's no flow.
because one can actually zoom in and actually show there is no flow. You can zoom in and see something echogenic within the vessel, and then you can look at the area of blood supply and see if there are features of infarction, because then there'll be changes in the echo texture of that blood supply. Yes, yeah. The gray-white matter differentiation will be lost. Okay. Yeah.
Yeah. All right, thank you. And image B, we're looking at the pulse wave Doppler, and we're seeing a greatly increased diastolic flow. And you can see the difference between the peak and the trough is reduced. So that indicates an increased diastolic flow. In the sonogram C and D, this one you have coronal, and this one, the image D, is actually a CT scan. So we have an increased area of echogenicity, which we're seeing on the parietal lobe around this area. And on the CT scan, we can't. There is still increased echogenicity, but here it was showing more of a mass effect with a midline shift from left to right.
So the echogenicity in the ultrasound was because of what? I see in your legend it was hemorrhage, isn't it, right? So it was actually hemorrhage that was causing that. But beyond that, again, you can see the sulci are not well defined in the ultrasound. You can see the ventricular system is compressed, especially on the ipsilateral. Yes, the ipsilateral frontal horn is compressed. There's actually a midline shift. Huh? And those thalami are looking quite enlarged. The basal ganglia. Yes, you cannot see, normally you should actually see the internal capsule. So the definition of the different nuclei that you see within the basal ganglia, you're not seeing them very well the way you normally would. And the same features are again better shown again on the CT. So again, you can still see the hemorrhage. You can see that loss of definition of the base ganglia, the diffuse brain edema, the midline shift, all those, again, that they're being shown very well. The CT has also added something which is not shown on this ultrasound unless one did axial images through the squamosal temporal bone. What has the CT added? Is there anything extra axial?
No, for this for this image, no, it was just showing the midline.
Have you looked at the image and seen?
Unless there's the only thing that I noticed is this.
Yes, but there's some extra axial collection. There's something there, yes.
This one, yeah?
Extra axial, my dear.
Yeah.
Go towards the... Yes, there. What is that fluid there?
Yeah.
There's something subdural.
Yes.
Go more anteriorly. Can you see that? More anteriorly. Yes, there. You can see the surface of the brain?
Yes.
Okay, I think you are totally bypassing it. But
I'm bypassing it.
Yes, Diana, are you seeing what I'm saying? Yes, where you are now.
Yes, where her pointer is, there's a subdural.
Yes, there is a subdural, which most likely to be an empyema because you're looking at infection. And for you to pick that up, yes, there's something hypodense there. No, in fact, it's actually isodense because the gray matter is actually a little bit more denser, more attenuating. There's something gray there. There's a collection there. And for you to have picked that on ultrasound, you needed to have done axial images, huh? Yes. Through the temporal bone, no? Yeah.
So that's subacute. It to be subacute.
No. Empyema.
Oh.
Empyema.
Because I was thinking.
Yeah. Because it's not going in between the south side, so it's not a subdural. A subarachnoid, it is a subdural. Yeah. Okay. Yeah. What we can continue?
Yeah.
What about the E?
All right. All right, so if we're seeing still the area of the left MCA, there was a focal echogenic infarct that was visualized at this area. That is now these are two different patients, and also F. There's also an echogenic area here. That's at the parietal region, which was noted, and that area also signifying a left MCA infarct. And in G and H, these are cases of Zika virus causing the meningitis, and you can see there's a calcification of the gray-white matter junction and also calcification of the corpus callosum that is visualized by they're denoting it with the arrows there in that area.
So this was more of chronic infection, or the patient had it in utero, eh? Because
Yes.
and for them to not calcifying, yeah. So in fact, you can see also how geographic they are. They have sharp margins in E and F, the margins of the infarct. Yes, yeah, when they get well defined, as opposed to the hemorrhage, which is more diffuse. Yeah.
Yeah.
So this the calcification for G and H, they say it was because of Zika.
Yeah. They're saying it's because of
Okay.
Zika.
So it includes, it's now added to the rest of the torches for causing calcifications.
So these are other sonograms. We have coronal through the frontal lobes in an 11-week-old infant with a group B strep meningitis. We're also seeing that there is diffusely echogenic leptomeninges that are denoted by the arrows, and also there's a subdural connection, most likely now an empyema of fluid within that area that shows up by the asterisks. Image C is a normal image. We are using it for comparison to B, which showed thickening of the supercellular systems, which is denoted by the arrows, and this is in the normal infant how it should actually look. So this is just these are just more
echogenic, and then you cannot even
Yes.
see the structures very well. You cannot see the brainstem very well in B when you compare it to C. Yeah. Okay.
Yeah. So again, just
and even the
more
ventricles are compressed. The ventricles
Yes,
are
in B.
compressed. Yeah, in B.
Yeah. Yes, they are compressed in B. Okay. So here again, we're imaging through the anterior fontanelle. Again, we're seeing just the same thickening that we have been talking about previously.
What's the change in technique here?
Now, I think here they're still doing it through the anterior fontanelle. I don't know if they're now zooming. Now it's more focal.
So what's the change in technique?
The change in technique.
Taleni?
They are using a linear probe to get
Yes.
the extraction spaces.
Yes. So linear probe, in fact, it's very good to show you the near field. It's very good for assessing the superior sagittal sinus. You want to look for any clots in it and things like that, thrombosis. Yeah. And so you can now see the fluid collections very well, and the thickened leptomeninges very well.
Yeah.
I know you knew it, Christine, so I hope you're not panicking or anything. Yeah. Just take a deep breath. And you've put in some pretty good images, by the way. Yeah.
Okay.
Yeah. So thank you for that.
Thank you. So this one again is just the same thickening of the leptomeninges, and here they were doing a measurement. They didn't say what measurement it was, but it was a study trying to figure out the difference in the thickness and whether it correlates with meningitis. But I just put this here so that we can see the thickening of the leptomeninges. So here we have a patient with E. coli meningitis, and here we have an infant. We have dilated ventricles, and within it we're seeing there's intraventricular septum. Within the ventricle itself, and then if we look at the walls of the ventricles, they appear hyperechoic, which denotes now ventriculitis in this patient. Yeah, so this is just the same where we're seeing the some connection within the ventricles, and there's increase in the thalamus-occipital distance in that area, dilation of the ventricles. So ventriculitis is another complication of meningitis, as we said, and you might have hydrocephalus with echogenic debris within it, and you can have also septum, which are visualized in these images. Yeah. So we go to CT scan of the head. So the CT may be normal in the initial stages. You might have also subtle hydrocephalus. You might have hyperdensities around the basal systems, and also leptomeningeal enhancement, which follows along the pile surface of the brain and fills the subarachnoid spaces and sulci of and systems. So this diagram here, I just put it here so that you can see the pattern of leptomeningeal enhancement that we will observe in CT and also in MRI as well. And if it's thin and bilateral, you're most likely to think of it as being meningitis as compared to the other findings that are in this.
Okay, so that's a very good. Don't go very fast, Orlando. This is a very good table. Huh?
So it even shows you the different kinds of the meningitis. You know, when it's thin, bilateral, it's more of pyogenic or viral. And then when you have unilateral, you think of sarcoid. Then you can add TB in our population or vasculitis. And but sometimes it can have small granulomas within, even within the meninges. So it's not really a smooth thickening that you would see in pyogenic. And for TB, you get quite a bit of enhancement of the at the basal systems, because that's where now the exudate tends to collect. And then when it's thick and nodular, it's like what you get for carcinomas. In fact, sometimes they can look like subdural collections for carcinomatosis or fungal, can give you that. But I wanted to say, meningitis per se, in terms of the diagnosis, it's actually a clinical diagnosis. The way the patient presents, fever, has all those signs that will point that there is meningitis. So what is the main role of imaging when they send a patient for who they suspect meningitis? What is the main role of imaging? What are they really interested in that we should tell them in the report? Because sometimes it may be normal, actually. In a good number of cases, it's actually normal.
Maybe it would be the complications that are associated with meningitis.
Okay, you see now you may not get, the main thing you might see there'll be maybe some edema, but the main thing you want to look for is if there's increased intracranial pressure, if there are any signs of herniation. So that's the thing that you really have to tell them, because they might want to do an LP, and they should be able to do that comfortably. Okay, so is there any ankle herniation? And those are things that you should all know how they look like. Okay, so any transtentorial herniation, or through the foramen magnum, that kind of thing, tonsillar herniations, those ones, that is what has to be very clear in your report. Because a normal CT does not say that the patient does not have meningitis. Okay? Yeah, we can proceed.
Okay. I think I'll add more images on that to show the herniations as well, because I didn't put it here. So in MRI, FLAIR appears to be the most sensitive technique for detecting meningeal disease. In T1, it may be normal, or the cell side may appear less hyperintense than normal. If you do T1 with contrast, you will see leptomeningeal enhancement. FLAIR demonstrates hyperintense signal in the CSF spaces, especially in the cell side. And then FLAIR with contrast is more sensitive and specific than T1 with contrast, and it will help you spot leptomeningeal enhancement with ease. And then you have the MRA, which might show arterial narrowing or occlusion. So in the table, we're seeing the differences, or what's not the differences, what you would expect to see with on MRI in either bacterial or viral. You'd have on FLAIR, the cell side would be hyperintense. You'd have leptomeningeal enhancement, subdural empyemas, secondary hydrocephalus, venous or arterial infarctions, and DW high in ventricles, cell side, and the perivascular spaces as well. So some of the
why is FLAIR so sensitive for picking up meningitis and more sensitive than even T1 with contrast? You have it there in your last bullet.
What? Sorry?
I'm saying you have it there in your second last bullet. So why is FLAIR very sensitive?
Oh, because you can spot the leptomeningeal enhancement because with the inversion recovery sequences. So the abnormal collection will be brighter in FLAIR compared to T1 with contrast.
Yeah, because FLAIR will only null fluid that is of CSF quality, isn't it, right?
Yes.
Right. So if there's any small alteration in the CSF fluid in terms of this increased protein, then it will not null, and that way it will be much easier to pick it. And that is why FLAIR with or without contrast will be able to pick up the meningitis. I hope you've put images of FLAIR.
Yes, I think I have a few.
Okay, fine, we can proceed.
If not, I'll add. If not, I'll add some more.
So here we have a male whose gestational age was 37 weeks and 2 days. The MRI was performed at the corrected age at 42 weeks and 3 days. And here we have post-contrast sagittal T1 images, that's A, B, and C. And we have a post-contrast as well, axial T1 muted image. And here what we're seeing is that there is ventriculomegaly. We have enlargement of the lateral ventricles and as well the third ventricle in that area. And we're seeing also leptomeningeal enhancement, which we're seeing visibly more in image B. And for D, we're seeing that there's increased, the ventricles appear enlarged and the choroid plexus is hyperintense in this image. But here we're seeing more of the leptomeningeal enhancement and now one of the complications of
Is that pachymeningeal enhancement as well?
I'm not so sure. I'm not so sure.
Because if you look at where you have the cystan magnum, there is some enhanced dura. Yes. You can see that. Area. Yes. All the way down. Yes, exactly. Yeah. So you have both lepto and pachymeningeal enhancement.
Okay. So here we have a male infant at 11 months with TB, meningitis. We have post-gadolinium images in axial and coronal planes. Here we have the intensity mostly at the level of the basal systems, and we're seeing there. And they're saying that there was an artifact.
That's what you've drawn out is what? What have you drawn out, my dear?
No, this is at the level of bone.
Yes.
So,
right, that's the basal system. But what were you drawing out?
It's actually the tentorium, isn't it? Tentorial notch.
Oh, Yeah, or maybe I think that's
So you can see the folia there. So that's the tentorium that you are doing. It's enhancing, isn't it, right?
Yes.
So here we have also pachymeningeal enhancement. Well, how would you differentiate this from bacterial or pyogenic and meningitis? And I mentioned that one is a enhancement, pachymeningeal enhancement. Anything else that you can see in these images? Very well shown in the coronal. Sharon?
I'm also not sure.
Sada? So look at the enhancement. Yes, Sada?
I'm trying to see if, so in terms of differentiating between pachy and infective.
No, the pachy, you're looking at whether it's just the dura is enhancing or is it just the leptomeninges. That one we have agreed it's already there. Because you can see, in fact, right round in the coronal, the dura is enhancing. And then you can also see the leptomeninges, what is going in between the sulci is enhancing. But just look at what is going in between the sulci. Is it just a linear line or is there something more?
You have this.
You have what?
You have this. No, I describe.
You have what?
I don't know how to describe them, but you have the focal lesions of like
yes, the like focal lesions. Isn't it rounded focal lesions? Yes, Diana.
Yeah.
Your hand was up. Oh, was it? Yeah, a mistake.
Yes, I wanted to say no. I wanted to say, is this what you were saying when you were talking about the electromeningeal enhancement, that it's nodular? You have
yes, you have some nodularity. And that nodularity is because of small granulomas, isn't it, right?
Yes.
So you can have those within the leptomeninges and also within the parenchyma, okay?
Yeah.
Small tuberculomas within the parenchyma as well. Yeah. So these are really very nice images.
Yeah, Doc.
Yes.
In a post
yes.
Right? Would we term it as a meningeal carcinomatosis? That description.
No. This is not carcinomatous. This look more of granulomas. Huh? It's diffuse. They're small. They're punctate, and then there's no history of CA. The patient is coming with features of meningitis and fevers and things like that. Yeah, maybe even history of contact with TB and all that. Yes, Sharon.
Yes, so just to clarify, there's that table we've just seen on the leptomeningeal patterns in the different conditions. So for TB,
let's go back, Orlando.
Yeah, so for TB, we had mentioned it's under thin unilateral, but the additional feature that we're seeing here are these granulomatous lesions. And in our case now, this image is showing bilateral disease.
Yeah, because it was very exuberant. In terms of, it doesn't have to be bilateral like this. It can just be in the base or just unilateral, depending on the progression. But in this particular child, it was quite exuberant. Yeah.
All right.
So for carcinomatosis, it's thick and quite nodular. And that one can be unilateral. Yeah. I think we've seen it in a few of the MDTs. Maybe we'll come across it. Yeah. Or you can look for it and see the differences. Okay. We can proceed. What was the thing about there was a low signal blood products?
Yeah, so they're saying there's a low T1 signal in the left ventricle that was associated with susceptibility artifacts. That was due to blood products. So that one I wasn't so sure. Yeah. All right. So what happened is the patient survived but had pneumonia and later on developed sixth nerve palsy and required a patient because of the enlarged ventricles. And we also forgot to mention there's also dilation of also the third ventricle. So here we have serration.
The lateral and the third, yeah?
Yes.
Yeah. Because you can see the inferior horns, huh? And especially much more on the left side up, it's quite dilated. Yeah. Okay, fine.
So here we have 3 separate cases of serratia meningitis. A patient, these were all T2 images, and they showed that the patient had large cerebral abscesses. Now, this was like one of the complications of meningitis. So we're seeing an hypointense area surrounded by hyperintense surrounded by a rim of hyperintense rim. Sorry, that is at the
capsule,
region.
right?
Here we have yes, the capsule, which is
the capsule will be hypointense because it is organizing. Yes. Yeah.
And then yeah, so we have the same abscess formation, bilateral in the parietal lobes and the frontal lobe, and also the same abscess formation in this patient at the frontal lobe. Same features. The center is hyperintense with a thin hypointense ring. Yes,
it's true. So, and the preterms had subdural effusions, but also you can see the brain development. Huh? Yeah. It was still quite premature brain, especially the one in the center. The middle one, there is no gyral development as such. Yeah. Could be earlier than 26 weeks, huh? 24 there. Okay.
Right. So we have cerebritis. It is a purulent non-encapsulated parenchymal infection of the brain. The term is used when the infection is caused by bacteria or a non-viral pathogen. Most patients present with late stage of cerebritis, which is now the abscess formation, and the clinical signs clinical signs of an intracerebral mass. The most common symptoms are fevers, seizure, nausea, headache, and vomiting, and focal neurological signs depending on the region of brain involvement. The spread can either be hematogenous or direct from an autogenic focus or meningitis. We'll go quickly through the pathophysiology, which correlates with the imaging findings as well. You have early cerebritis. You have direct inoculation of the organism into the brain parenchyma, which will result in focal inflammation within 1 to 3 days, and at this point is where we refer to the disease process as early cerebritis. So there is increased permeability of the blood vessels without angiogenesis. In late cerebritis, you have polymorphic neutrophils, which are recruited and leads to edema. You have glial cell activation, and there will be an area the area of inflammation will continue to grow as the central zone develops coagulation and necrosis. This is around 3 to 6 day mark of the infection. A well-vascularized ring of enhancing fibrotic capsule forms after approximately 2 weeks, which can be seen in CT, and then the host will usually mount a defense to the infection, and which will lead to now the capsule formation, which will now wall off the infection to that particular area, and that's why now you have the abscess formation. In the fourth stage, it is marked by considerable gliosis on the cortical surface of the abscess, and tissue destruction is dependent on the virulence of the organism and the host response, how active the body can mount a response to it. So early cerebritis on CT may appear normal by CT, but you can also have polymarginated cortical or subcortical hypodensity with mass effect corresponding to the edema. You have little or absence of enhancement, or also you can also have
plus or minus small areas of hemorrhage. In late cerebritis, it is more defined than the early, but it's still irregular, and there's a rim enhancing lesion with a hypodense center. So we'll go through some images showing early cerebritis. I wasn't able to find for a child, but at least we can see how it will appear. So these are MRI images in the axial. This is T1 image. The first one is T1 image. The image B is a T2, and image C is a T1 with contrast. And we have both our DWI and our ABC maps on the image.
What did you say image
So,
B
and
is?
B, T2. Although I saw this one, but I wasn't sure it was
T2?
I think it was, yeah, I
It's
saw
true.
T2. They labeled it as T2, but no, I'd rather.
Unless it's a flare. It's a flare. Unless it's a flare.
Yeah, so the T2.
Because the white matter looks grey, yeah?
Yeah.
Yeah,
So
and then the signal in the aqueduct is not really nulling, yeah?
Yes.
Yeah, in the aqueduct.
Yeah.
Okay.
Yeah, so on T1 image, we're seeing an area of an hyper intense area. This is at the right temporal lobe. This is around at this level. And on image B, we're seeing on flare, we're seeing that there is now the abnormal intensity, which is hyper intense, still at the area of the right temporal region. On T1 with contrast, the lesion itself is not picking up any contrast, so it just remains hypointense as compared to the T1 image. And when we go to our DWI, we're seeing that the lesion is bright on DWI with a low ABC map with a low ABC value, so which shows that there is some restriction that is in this area. So these are features of early cerebritis, because we're not seeing it is not an encapsulated, so it's more of the diffuse lesion that just presents initially before we progress into the next stages.
Yeah, before D. So D and E were much later, isn't it? When you had the abscess forming.
Yeah, it's more.
So for images A, B,
Yes,
and C,
yes. Would you have another differential apart from cerebritis?
It would be infarction as well.
Infarction, because it's a vascular territory, you have to check and see if it's going to be within a vascular territory. Yes, yeah. So infarction, what else? And then, of course, you look at the blood vessels and see if there's any thrombosis within them and things like that. Any other differential? There's a viral infection that localizes many of the temporal lobes, especially in adults. Have you come across any of it? It's herpes simplex 1. Eh? So they will give you the similar features, A, B, and C. Just that you'll not have the abscess. Yeah. Okay.
Okay. Right. So this is the history of this patient was a patient with dermatomyositis who presented with severe headache, left pyramidal syndrome and fever that was documented on admission. So here we have a contrast enhanced CT scan and axial CT scans, and what we're seeing is that there's a hypodense lesion in the right thalamus area. That's at that level. So if we continue cranially, so we're coming lower down, going up, we can still see the lesion that is there.
What is a left pyramidal syndrome? Oteko.
Dr. Oteko, what's a left pyramidal syndrome?
Dr. Amusha, never heard of it. Not sure.
Any suggestions from the class?
Christine, what did you think it was?
What I was thinking, maybe the what was I saying? More of the signs because of compression of that area there. The brain.
Pyramidal syndrome.
The pyramidal tract is compressed.
Yes, lobe tracts, corticospinal tracts. They go through the pyramids.
Yes.
Yes.
So the
And you can see.
motor.
Yes. You can see that mass that is involving the posterior limb of the internal capsule, right? And also the adjacent thalamus because of the edema. How would you see this more clearly?
Yes.
Is there something you can do? Because if you're in a hurry, you might actually miss this. Is there something that you can do? That you need to be doing whenever you're looking at your brain windows? Have you ever heard of something known as a stroke window? Have you heard of that, the stroke window? So you can actually reduce the window level. So that means it makes the gray-white differentiation more marked, so that if there's any place whereby there's lack of clarity, lack of sharpness, then you can suspect there's a problem going on there. And it's very important, especially where you're suspecting there could be stroke, because you can now look for those subtle signs of stroke, early stroke. Yeah. So it's called a stroke window, whereby you reduce the window width to even, normally it's around 80, 60, you can reduce it to 50 and below.
Makes the image more noisy, more grainy,
but your gray-white differentiation becomes much better. And so once you do that, you can now see even more lesions within the parenchyma. Because there's also something that was developing in the right frontal lobe in this patient.
Yes, the same intent.
Yeah. Okay. Yeah.
So as we continue, finally, we're just seeing the same lesion, hyperintense, and there's some mass effect, the displacement of the falx to the contralateral side. And we've seen that there's compression of the thalami and the posterior limb. Yes, so basically that's the same lesion all the way up to the body of the lateral ventricle. So the lesion is just similar, and it's not taking up contrast. So again, here we're going to see the progression in a patient with cerebritis to formation of overlapses. Here we have a T1. This is a DWI, the diffusion weighted image, and you have T1 with contrast. Yes, and here again the same. C is T1 post contrast. That's after 7 days. So again, we're seeing just a diffuse lesion, which is hyperintense on T1. This is at the parietal lobe posteriorly, and also at the left parietal lobe. Here we're seeing it. Here they said it's a diffusion weighted.
Exactly. Yes.
Yeah.
So it's a DWI. I thought I heard you say T1. Or did I hear wrongly?
Yes, I had said that, then I quickly changed.
Okay. Yeah. All right. So actually, what would you say in your reporting? You'd not be saying hyperintensity. What would you be saying? You're saying areas of diffusion restriction, right?
Yes.
Yes. Yeah, you can see it's really adequate DWI because the CSF is darker. So they have tried to remove all the T2 effect. Though one could always look at the ADC map to correlate. Yeah. And those areas which had the diffusion restrictions are the ones which are now enhancing on the T1 with contrast. That is the C. And B is also a T1 with contrast. When was that done?
T1 with contrast. Now I think my thinking was A and B were around the same time. And then
yes, A and B was the same time. And it was showing how DWI shows the disease earlier.
There's more information.
Yes, earlier
Yeah.
than a T1, even a T1 with contrast, because the B looks actually normal. Yeah, unless you start saying maybe in that left right occipital lobe, it's a bit you don't see the south side very well. They're a bit hazy, so there's some edema there. Yeah. And maybe some increased vascularity, but it can be a bit dicey to call it. But if you look at the DWI, you can be much more confident.
Yes. And then on AHCC, the MRI done at CIC was done 7 days later, and now at this point in time, now we're seeing the ring enhancing lesion, which now shows that the patient had progressed now to form a cerebral abscess, multiple cerebral abscesses in that area. So sorry, I skipped a slide. So we're going to cerebral abscess. Now the difference between the abscess and cerebritis is that in abscess, it is a focal, purulent encapsulated parenchymal infection of the brain. It begins as a localized region of cerebritis, as we've just seen, and then it evolves into a collection of pus and immune cells that is surrounded by collagenous capsule. The clinical presentation depends on the size and the location of the lesion, the virulence of the organism, and the underlying condition as well. The signs of rapidly expanding mass, which will include headache, drowsiness, confusion, seizures, focal neurological deficits, or speech difficulties and fever. So the pathophysiology, it can come from a direct spread from a local infection, or it can be hematogenous from a distant source. It can be caused by trauma or neurosurgical complication. So if it's from a direct, the areas that would most likely cause an abscess by direct spread is if a patient has otomastitis and sinusitis and an odontogenic abscess, which would be the causes of direct spread, which will be through the bone or valveless hemispheric veins. In a patient with otomastoiditis, the abscess will most likely be in the adjacent temporal bone or the cerebellum. In a patient with frontal or ethmoidal sinusitis and odontogenic infection, the abscess will most likely be in the frontal lobe. And we already mentioned the hematogenous spread. Yeah. So the radiological features, you will have a ring of iso or hyperdense tissue, which is uniform in thickness. The central area will be of low attenuation, which will most likely be fluid or pus, and the surrounding low density due to the vasogenic edema around it. You may have ventriculitis, which will appear as enhancement of the epidyma, and you might also have hydrocephalus, which is commonly seen with intraventricular spread. On T1 weighted, on MRI, on T1 weighted images, you'll see that the center is low in intensity compared to the if you compare to it will be hypertensive compared to the CSF. Yeah, but it will be low intensity, and then the peripheral will be low intensity as well due to the vasogenic edema, and there will be ring enhancement, which will be hypertense, and ventriculitis, which will be there. In T2 and flare, the center is of high intensity, which is hypointense to CSF and does not attenuate or flare. And then peripheral will be high intensity due to vasogenic edema, and abscess capsule will be visible as an intermediate to slightly low signal changing. On MR perfusion, the relative cerebral blood volume is reduced around the edema.
Yeah, and in MR spectroscopy, there might be increase in lipids and lactate, succinate, acetate, and amino acids. That's listed there. On DWI, you have a high DWI signal, usually present centrally, which represents true restricted diffusion. Peripheral or partial restriction may also be seen. If a patient is immunocompromised, the center may not show diffusion restriction. On susceptibility weighted imaging, you have a low intensity ring, which is complete in 75% of the cases and smooth in 90%. And you might also have a dual ring sign. So we'll just put all that together in the following images. So here we have axial CT scanned both in bone window and brain window. And we have the brain window is post contrast. And here we're seeing that there's opacification of the right mastoid area, that's on that area. And once you do the brain window, we found that there was a ring enhancing lesion with a central hypodense region and an hyperdense skin. That is on CT with contrast. Yeah. And there was also effacement of the ipsilateral lateral ventricle and a midline shift. That's now to the contralateral.
So you'll be talking about there was a hypodense lesion, fluid field, with a ring enhancement surrounding perilesional edema, midline shift.
Yeah.
Okay. Yeah.
So here we have another axial CT scan. Here we're seeing a ring enhancing lesion that is present at the right, at the frontal horn of the lateral ventricle, and there's also effacement of the ipsilateral horn of the lateral ventricle. There's a ring enhancement and also a central area of central hypodense lesion, and you have esogenic edema that is visible around the lesion itself, and there's also a slight midline shift when you look at the falx cerebri in that area. And for the same patient, we're seeing that there is hydrocephalus that is present as well, and the same effacement of the bacillus system. So that's the lesion.
Which cistern is shown that is effaced?
The same bacillar system.
Which cistern is shown that is effaced? No, not in that one. That one, what you can see that is effaced is the south side. Yes, it's the south side. But you can see the pineal gland. In that one, you can see the south side effaced. In the first image, you can see the pineal gland.
Oh, yeah, there should be, yeah.
So which cistern would be there? Yes, exactly. Yes, yes, it's effaced. Right.
Yeah. So we'll shift gears and
also the third ventricle is dilated.
Yeah.
That's not the third and the lateral,
Yes. So we'll go through neonatal germinal. Yes.
Yeah, Derek has a question.
It's not really a question, but I just came across that mnemonic I've posted. I think we have covered majority, or we have actually covered all of them. So just for maybe remembrance, not forget something.
Okay, maybe you send it to the WhatsApp group so that I can see as well later.
Yeah, I'm also sending it.
Okay. Thank you. So we may proceed. So now we're going to go through neonatal germinal matrix. Okay, we're going to go through neonatal germinal matrix hemorrhage, but first we get a basic understanding of what the germinal matrix is. The germinal matrix develops deep to the epidermis, and it consists of loosely organized proliferating cells that give rise to the neurons and glia of the cerebral cortex and basal ganglia. It is the vascular bed and it's the most richly perfused region of the developing brain. The germinal matrix is not visualized on sonography. However, you visualize its typical anatomic site, which is over the caudate nucleus, where the hemorrhage occurs in premature infants. So early in gestation, the germinal matrix forms the entire wall of the ventricular system. After the third month of gestation, it regresses around the third ventricle, then around the temporal, then around the temporal and occipital horns and the trigone. At around 24 weeks, it's only present over the head of the caudate nucleus and to a lesser extent over the body. When we progress now to 32 weeks of gestation, it is unusual to see germinal matrix hemorrhage because the cells migrate out to the cerebral cortex. So the regression continues until 40 weeks when the germinal matrix ceases to exist as a discrete structure. Right. So now we go through the germinal matrix hemorrhage. It occurs primarily in premature infants less than 32 weeks, as we have already described. It is greater in infants with gestational age of less than 30 weeks and a birth weight of 1,500 grams, or a combination of the both. The hemorrhage may lead to intraventricular hemorrhage, hydrocephalus, and porencephaly, which is an extremely rare disorder that causes a cyst or a cavity filled with CSF to develop in the brain. The risk factors are prematurity that are complicated by an altered cerebral blood flow, such as hypoxia, hypertension, hypercarbia, or hyponatremia and rapid volume increase, and now pneumothorax when a baby is already born. And other causes are increased cerebral venous pressure at delivery, congestive heart failure, for the babies who are getting ventilated, increased ventilatory pressures, and coagulopathy as well. So there's a classification for the germinal matrix hemorrhage, and you have already said where it occurs, and it may also affect. You may have also subependymal hemorrhage, which is classified as class 1. You can have intraventricular extension with or without hydrocephalus. If it's without hydrocephalus, that is grade 2, sorry. If it's grade 3, you have the intraventricular hemorrhage with hydrocephalus, and grade 4, you have intraparenchymal hemorrhage with or without hydrocephalus. And the classification is by Burstein and colleagues. So we'll go through the 4 grades of germinal matrix hemorrhage. So here in grade 1, which you said it's subependymal hemorrhage, it occurs as a homogeneous, moderately to highly echogenic mass or lesion. The clot often causes focal hemorrhage at the caudothalamic groove, and it may bulge into the choroid plexus. As the clot ages, there will be changes with the clot, and you will have the central area become sonolucent, and there might be an echogenic rim around it as well. As the clot heals or retracts, you might either have two options. Either one, it will be a complete resolution of the hemorrhage, or you can have formation of a subependymal cyst. So here we have sonograms, we have axial, coronal, and parasagittal views. So here we have an echogenic area at the subependymal area. This is at the left, the left ventricle, and yes, this the focal area.
The left caudothalamic groove.
Caudothalamic groove. Yes.
Yes. Yeah. It's subependymal, just like what you've said. So it's not within the left ventricle; it's still subependymal. Yeah. Though there's some mild prominence of the left ventricle, but sometimes they're usually not symmetrical. Usually, the left one tends to be larger. as one of the variants. Yeah, but you can see the B and C, the differences, and very well shown in image D.
Yes.
Where they use the
Yeah,
linear
so
probe, yes, we're able to focus on that area quite well.
yes. Yeah. So you can see that the echogenic area at the chordothalamic groove, and then at this, with the sagittal view, you can clearly see the hemorrhage, and it's the choroid plexus at that area. So this is a case of grade 1 subependymal hemorrhage. Grade 2, you have intraventricular extension without hydrocephalus. So the intraventricular hemorrhage may appear as hyperechoic clot that fills a portion of the ventricular system, or the whole ventricle can form a clot. So you can have a clot within the ventricle, encasing within the whole ventricle. So the clot may obscure the ventricle owing to complete filling of the lumen. So the echogenic choroid plexus may appear as asymmetrically thick and may be difficult to define within the ventricle. But as the clot matures, there will be those changes that you had said, that the center will become echolucent. So you will be able to differentiate it better from the choroid plexus. You might also have low level echoes from debris floating within the ventricle as the clot breaks apart. So this is a case of intraventricular hemorrhage. This is true that we have anterior fontanelle views in A and C, and we have posterior fontanelle views in B and D. So these are two different neonates. in the sagittal image here, this is through the anterior fontanelle. We're seeing an intraventricular hemorrhage within the occipital horn of the lateral ventricle. So you're seeing it at this area, and you can better visualize the same hemorrhage in the posterior fontanelle view, and you can see that there's an echogenic collection, so which is the hemorrhage within the posterior the occipital horn. And when we move to image C, this is of another neonate, but with a similar presentation, with an echogenic collection within the occipital horn of the lateral ventricle. And here, image D is showing now the changes with time, because if you realize and see, okay, you can't clearly tell. There's some that you won't be able to tell the difference between the choroid plexus and then the hemorrhage. But as the clot ages, it becomes now more sonolucent, and you can differentiate it from the adjacent choroid plexus, and that's what image D and E is showing. And these are posterior fontanelle views.
Yeah, what else you can do is do coronal images. So the corona, if you're at the C5 level, you're having both the two choroid plexus, you can compare the way they look, and if one looks more larger, more bulgy, you can now suspect that there is a type 2, a germinal matrix hemorrhage. Because usually the hemorrhages will never be symmetrical, but the choroid plexus are fairly symmetrical, yeah. But what you're saying is true about it liquefying with time and looking different, yeah.
So we go through grade 3. This is now intraventricular extension with hydrocephalus. So there's intraventricular enlargement, and the clot is seen in intraventricular enlargement, and it may be dependent depending on the position of the baby, or it can be adherent to the ventricular wall. Again, with time, we have the changes that we had previously discussed, and post-hemorrhagic hydrocephalus may require shunting, and you require to do follow-up scans obtained weekly unless the head grows rapidly or any other crisis intervenes, which will make you now do the scan shorter than 1 week. So again, we'll go through grade 4, intraventricular hemorrhage, and grade 3, sorry, intraventricular hemorrhage. And here we're seeing in the coronal images, we're seeing that there's
ventriculomegaly. This is the lateral ventricle is enlarged. The left more than the right, and the rim is echogenic as well. I found the rim a bit echogenic, and the CSF as well. There's some low-level echoes within the CSF. In image B, we have a sagittal image. Here we're showing dilation of the third ventricle. Yeah, so causing the third and the lateral, so causing some obstruction. And the image C and D again, here we're seeing again just the obstructive hydrocephalus, which is extraventricular, which means that the whole system is affected. Yeah, and we're seeing enlargement of almost all the lateral third and as well the fourth ventricle, which is enlarged.
Image C, is there a clot?
Yeah, within the image. Sorry.
C.
Yes,
Uh-huh.
yes.
Yes.
There's a clot. It's attached to the wall of the lateral ventricle.
Yeah, which is showing central liquefaction. Yeah?
Yes.
What's that we are seeing in the third ventricle?
In the third, they hadn't mentioned what it is.
Does anyone have an idea what it is in the third ventricle? Yes, Sharon?
The thalamic adhesion?
Yes, it's interthalamic adhesion. So that's a thalamus. That is just shining through. Yeah, okay.
Okay. Okay, thank you. Yes, I think someone has a question.
Oteko has a question.
If you have a choroid plexus papilloma, how will you differentiate it with grade 3? Because it also will be echogenic. You'll have hydrocephalus. It's really on imaging, when you do a neonatal ultrasound, when you have a choroid plexus papilloma and you have an intraventricular hemorrhage grade 3, I don't think it will be very easy to differentiate.
Papilloma will be a mass, and it may or may not have hydrocephalus, but if there's hydrocephalus, it's going to be diffuse, it's going to be extraventricular hydrocephalus, because it'll just be increased CSF, isn't it, right?
Yes.
Yeah, and it will be a well-defined mass, and you can do vascularity, Doppler, and should show vascularity, because it's a solid mass, as opposed to hemorrhage, which has very heterogeneous, very bizarre shapes, like the ones she's showing us, sometimes it just, hemorrhage can have a very varied kind of appearance. And then the other thing that these are premature babies, so again, you're more likely to have the germinomatrix hemorrhage, where a papilloma would be much more common, maybe in an infant. But of course, if you now suspect there's a mass, you'll go ahead and do a CT scan or MR, and then with gadolinium, you can look at the enhancement pattern. Let's continue.
So again, all right. So we have again sonograms. We have intraventricular, and we have ventricular enlargement with the hemorrhage, but bilateral. And here they were showing that it is dependent, and you also have an echogenic ventricular lining. So the epidermal is right. So there's ventriculitis in this patient. So we go through the grade 4, which is an intraparenchymal hemorrhage. So it is usually in the cerebral cortex and is located in the frontal and in the parietal lobe, because it often extends from the subependymal layer of the podothalamic over the podothalamic groove. So it appears acutely. It will appear echogenic. It will be an echogenic homogeneous mass extending into the brain parenchyma. Again, as a clot retracts or ages, the edges form echogenically. around the center, which becomes sonolucent. The clot may move to a dependent position by 2 to 3 months of injury. You can have parencephaly or encephalomalacia, which may develop. So here we're seeing parenchymal hemorrhage. These are cranial sonograms of 2-day-old infants, which shows the progression. The images were taken at, this one was at 2 days, B was at 17 days, image C was at 29, and D was at 2 months old. So here we're seeing an intraparenchymal hemorrhage, which is echogenic. It's not really well defined. It's on the left, right next to the lateral ventricle. For this image, I also thought that there was also an intraparenchymal hemorrhage as well on the right, with an intraventricular hemorrhage as well. As the clot aged with time, we're seeing the center became sonolucent with an echogenic rim. And at 17 days old, we're seeing the clot just maturing more, and you're seeing the same features now, just some sonolucent areas with an echogenic rim, but it's all within the parenchyma and the ventricular system. So this was at 2 months old, and we're seeing one of the complications of what might happen after. You're seeing that the clot has regressed more around the right, but on the left, if you look at the lateral ventricle, you have this cystic mass, which is now connecting with the lateral ventricle, and this is a case of parencephaly. So this is CSF, and it has an abnormal communication with the ventricle in that area.
Yeah, it's known as the parencephalic cyst. So that area of infarction is becomes cystic encephalomalacia, and when it communicates with
ventricle, it's called a parencephalic cyst. If it just remains within the parenchyma area, then it's just an encephalomalacic cyst.
Okay. So again, now we have more images. Now we're showing another form of complication of the periventricular hemorrhage. So we're seeing again a lucent area within the right lateral ventricle, and the white matter is also is echogenic. And we're seeing the clot as it ages with time, with the center being sonolucent with an echogenic rim. Once now we come at D, this is a patient at, sorry, I forgot to give a small key. So the first image, the baby is at 3 days old. Then B, we're going at 12 days. And then C, we're at 19. And then at D, we're at 1 month, and at 2 months old, we're seeing that there's a periventricular leukomalacia, the formation of cysts bilaterally. So this is a sign of white matter damage that is seen bilaterally, that is caused by the hemorrhage. So you can have either the periventricular leukomalacia or parencephaly that you can see as a complication. All right.
Yes, so the PVL PVL is a parenchymal complication of where you have more diffuse areas of infarction, yeah? And you can see as the infarct ages, there's initially volume loss. You can see there's widening of the CSF spaces. So yes, by the time you're reaching E, you can see that you have some those hygromas. Yes, subarachnoid, extraaxial hygromas. Yeah.
Oh.
Okay.
Okay. So we go through intravenous malformation. These differ from the adults in their angioarchitecture, their presentation, and systemic hemodynamic impact and the functional outcome of the patient. There are
Sorry, they are frequently fistulous or multifocal, and they may cause a hemodynamic effect on the entire venous system. The children will present with features of cardiac overload as a key clinical feature, which will increase morbidity and mortality. So you'll have changes in the chest X-ray as well for these children. So we'll go through the vein of Galen aneurysmal malformation, which is also known as median prosencephalic arteriovenous fistula, which is the most common neonatal intracranial vascular malformation. It is caused by the precursor to the vein of Galen, which is the median prosencephalic vein, which is there typically before birth, and it changes. So the anterior portion regresses to form the internal cerebral vein, and the posterior remains as the vein of Galen. And so what happens is that we have this vein, it balloons out to become an aneurysmal vein. So there are two types. There's a true and a false vein of Galen aneurysm, and you have arteries. For the true, you have arteries that drain directly into the dilated vessel without connection to the deep venous system. And in the false, you actually have the vein of Galen, which is formed, but you have also subpial AVNs and you have other vessels draining into a normally developed vein of Galen. So here you have a sonogram showing the same image. So what we're seeing is are areas that are hypodense. No, I have to remember this.
Yes. So you are seeing anechoic or fluid spaces, right? But the main thing is actually, because remember also there you have the brainstem, and because of the way the beam is going through, you may miss actually some part of the brainstem at that particular area. But the fourth ventricle does look dilated, and so does the third, which you can see the interthalamic adhesion. But what is important is what is seen posterior, in the posterior cranial fossa. There's a cystic lesion. Yes. So whenever you see a cystic lesion, you have to put Doppler, because it could be a vascular malformation, in a grayscale imaging.
So it's when now they did the Doppler, and then they could see the cystic lesion is filling with flow. Yes.
Yes. So for this one, we're seeing communication of, we have the ventricallosal and the posterior choroidal arteries draining into what was seen as a cystic lesion, which was now the vein of Galen. We have a classification system of the vein of Galen aneurysm malformations. We have the choroidal type, which is more common in the neonates, and the mural type. I don't know if I should go through all of this or we just speak, Doc.
Yeah, I think you can let your colleagues read it later on. Let's proceed.
Yes, so the clinical presentation, we say there's high output cardiac failure in the neonates, and you have also 80% of the output will be shunted through the fistula. That's why you have an output failure. So you have in neonates, you have the choroidal type with a high output cardiac failure, and the patient will also have cranial bruise. And for the infant, you have more of the mural type with hydrocephalus, which may occur due to venous hypertension or aqueductal stenosis, and in child you also have mural type, and the child will have developmental delays and hydrocephalus. So here we have a CT angiogram. Of fetus, and we saw it. It's showing an aneurysm in the deep venous system, which is here. This is where we're supposed to see the vein of Galen if it was normal, but we're seeing it is ballooned, and there is extension to the falcine sinus, and eventually into the superior sagittal sinus, which is dilated as we go down onto the transverse and the sigmoid at that area. And
so you see there is that abnormal vein they were talking about, that venous anomaly that's extending. upwards to join to the superior sagittal sinus. So you don't have the straight sinus in this particular patient because of that venous anomaly. Yeah. The internal cerebral veins are very short and they are seen much more anteriorly. The short ones, you see them anteriorly. One of them is quite dilated. Yeah. Okay, we proceed.
So you have
the ones that are
representation. Sorry.
The tributaries directly to the venous anomaly. You can see those tributaries. Yes. Yeah, the smaller ones. Yeah, that go directly to it. Yeah.
Yeah. So the clinical presentation here, you have a progressive enlargement of the head, and here we have an MRI. This is a T1 in the sagittal, and what we're seeing is that there is a flow void that is visible here, and this is where where the vein of Galen malformation is. Yeah, just above the pineal region there. Yeah. So it was a scrollable image, so I just took a few representative images, and here we're seeing the larger flow void with multiple joining tributaries, which are the smaller flow voids that are visible there, and we have hydrocephalus as well, dilation of the lateral ventricles. That's area. And then here we have a clinical history. This was a 22-year-old preemie with 8 months of amenorrhea. She was referred for an antenatal ultrasound. This was of her first fetal ultrasound. The fetus was corresponding to 31 weeks by fetal biometry. And what we're seeing is that there's a central anechoic lesion. It's cystic, and we have a tubular structure that is seen it appears cystic, and we have a tubular extension to it. and this feature kind of it is a classic sign of the comet tail. And once we put color, we were able they were able to confirm that it was a vascular. There was a flow within that.
Do you have some warm water to drink, Christine? Because you're having quite a cough. You would like to get some?
Yeah.
Yeah, please do.
I'm not currently at home.
Oh,
yeah.
okay.
I don't
you
have
are. Okay,
yeah.
fine.
Yeah, but
all right, let's
yeah.
Continue then.
Yes. Yeah, so here you're seeing drainage into the straight sinus and ultimately now into the sigmoid sinus now. So we'll proceed to Moya, which is a progressive cerebrovascular occlusive disease of the bilateral internal carotid arteries, which leads to compensatory abnormal vascular network at the base of the brain. It has a bimodal age distribution. There's one in early childhood, which peaks at the age of 4, which occurs in two-thirds of the patients who present with this, and then you have those with who present at the age of 30 to 40, and it's in one third of the patients with Moya. And in children, we have more of ischemic strokes, and adults, we have more of hemorrhage. And also some watershed infarcts. The radiographic features, you have small abnormal net-like vessels which proliferate, giving a puff of smoke appearance, which is seen more on direct angio, and it's not always visible on CTA or MRI, but what you can see it sometimes. And in 50% of the patients, it has involvement of the posterior cerebral arteries. There's also cerebral atrophy, which is common, and you'll also see watershed infarcts, which are common. On MRI, you'll see arterial stenosis, which is best seen on MRI, or enlarged perforators, best seen on T2 weighted. And then the vessel wall imaging will show concentric luminal narrowing, none or minimal enhancement. homogeneous T2 signal and no outward remodeling of the vessel. So we go through a short clinical history. It was a 7-year-old African-American girl who presented to the pediatric emergency department with an acute mental status change. The parents reported that she had woken up after a nap. She was agitated and confused. She was observed to stand up from the car seat and she was restless and wanted to exit the car. She was able to speak a few words, but they were not in the proper context and she was not able to follow any directions, but she was able to walk with support. There were no convulsions, head or eye deviation seen, and there was no incontinence or tongue biting. They did a CT angiogram, a CT head, and on this image we have an axial non-contrast image, and what we're seeing is that there's a posterior parietal encephalomalacia that is visible here. It's hypointense, barely visible if you're not ready.
It is hypotense. So how do then it's encephalomalacia?
Thank you. There are signs, it's gliosis, isn't it, right? So there are signs of volume loss. Huh? So if you look, just the adjacent south side, they are more dilated than on the contralateral side. And that occipital horn is more, it's displaced, it's like it's pulling towards it. Huh? It's displaced more towards it. Yes, yeah. So there are features of volume loss. And because of those features of volume loss, no matter how subtle, that's why you now would call it encephalomalacia.
Also, the volume loss will cause now the structures to be pulled towards the...
Yes. There's volume loss because of gliosis. So there was an old stroke there, an old infarct that healed with gliosis, and what you're just seeing is hypoattenuation. If it proceeds, it can even give you a cyst formation. Okay? But even where you have encephalomalacics, there is loss of volume because there is a brain injury damage, yes. Parenchymal damage, yes.
So with this is an MRI with gadolinium that's T1 rated, and you're seeing a left parietal cortical infarct, which is hypointense. Yeah, with prominence of blood vessels, the flow voids within the basal ganglia and the thalami bilaterally. So you're seeing already the increased vascularity in that area. And
those flow voids are which vessels are you looking at? What is it? What is the blood supply to the basal ganglia and thalami?
It's the perforators.
So those are dilated perforators. The prominent perforators. Why are they prominent? Why are they prominent?
Why are they?
Prominent, yes. Why are the perforators prominent? Why are they enlarged? What is the pathophysiology? Did you do the pathophysiology of moya moya?
Yeah, there was vasocclusion. There was a stenotic area. I think I did it in summary.
Of the?
of the internal artery.
Of the internal carotid. Yes. Of the internal carotid, sometimes the cerebral arteries. So you have dilatation of the perforators, so you can get an alternative pathway of blood supply. Okay. Yeah. So these dilated perforators are what on the next imaging modality on a DSA look like a puff of smoke. So you can see you're not seeing the distal end, or you're not seeing the
middle cerebral artery because it has been occluded, but you're having now that puff of smoke from those the moya moyas. Yeah. So yes, Diana.
I'm seeking a clarification. Why are the perforators dilated?
The perforators originate directly from the circle of Willis and those blood vessels, right? So if you have perforators already originating before the area of occlusion, they're going to dilate to supply the basal ganglia and to try and also provide an alternative route of blood flow.
Okay, thank you.
Remember, it's a chronic process, so it takes a while for this to develop. And initially, sometimes not very effective. So these children tend to get multiple strokes. Yeah.
Okay, thank you.
Okay. So I think we've already described this. So A is a left common carotid angiograph showing extensive external carotid leptomeningeal collateralization. I'm not so sure it is. This one is a bit hard, but there's also complete occlusion of internal carotid proximal to ophthalmic segment.
Yes, yes. Remember the external carotid, it gives you blood supply to the meningeal arteries, right? To the meninges. And so you can see those vessels from the internal maxillary going up to anterior, the meningeal arteries. You can see there are branches which are going into the brain parenchyma, which is unusual. So it's again just trying to get an alternative source of blood supply. There is, if I remember in Granger and Allison, when you're looking at the vascular supply and the vascular territories, when they're dealing with stroke, there are those channels. You have anastomotic channels between the internal and the external carotid, but usually they're very ineffective. But where there is a problem and an obstruction, they develop. So there is a linkage of those two systems, and this is one of the disease processes that can cause a development of those channels between the external and the internal carotid systems. So you can go and have a look at it, or just Google, and you will see what is available. But it's always nice, by the way, to read a textbook so to can solidify, fill in the gaps, so you don't have patchy information. Yeah. So it is recommended you read and we bring the analysis on cover to cover, or Saturn, or whichever book you have decided is going to be a textbook. You read it cover to cover. And then, of course, as you go through the systems, you look now for the specific, for now additional reading. So like in MSK, Resnick is a book to read. And Resnick has volume 1 to 6. That is a book to read for MSK. Yeah, for CNS, of course, now it's Ann Osborne. Okay. But the baseline is you get the standard textbooks and you read from cover to cover. Saturn is more, I think Saturn is what UK used to use quite a bit, but and Granger is more US. Yes, Derek. Which one are you using? There's also Brandt.
Yes, now you have brought it up. One of the IR fellows was recommending it. I think our colleagues on the other side of the town in Aga Khan are really using it. So I think we can.
Yeah, Brandt, and they're shining. Brandt it's short form. It has bullets. So if you also like reading something with bullets, you can use Brandt. That is quite whatever, as opposed to reading prose, whereby you read the prose, you understand, you make short notes, and then it just depends on how you like your reading. Yeah. And you have to do better than Aga Khan, eh?
Huh?
Yes. So you have to pull up your socks.
Okay. Yes. So we'll continue to perinatal brain injury. We'll talk about hypoxic ischemic encephalopathy. It's a state of disturbed neurological function in units caused by a number of different etiologies. Most common is intracranial hemorrhage and neonatal stroke. There are also some maternal causes. You have cardiac or pulmonary disease, placental insufficiency, shock, abruptio placenta, cardiopulmonary arrest, which all cause birth asphyxia, and the maternal drug abuse, which is cocaine use. The physiology and presentation, you have the arterial watershed, which determines the regional pattern of brain damage. So in infants, we say that the watershed is in the immediate periventricular region, so that's why you'll have mostly the general matrix hemorrhage and the periventricular leukomalacia occurring in the premature infants. So the neurological manifestation is less severe, and you'll have cognitive deficits, you'll have spastic motor deficits and spastic diplegia and spastic quadriplegia as well, and intellectual deficits. In the full-term infant, the damage occurs in the more cortical and subcortical regions because the watershed area moves now to those areas of the brain. So you'll have more of a parasagittal infarction. This will manifest as seizures, movement disorders, including arching, fisting, outer tone, absent suck, and depending on the severity as well, intellectual deficits. So we'll go through white matter injury of prematurity or periventricular, also called periventricular leukomalacia. So it's an ischemic lesion of the premature infant, and it's caused by infarction and necrosis of the periventricular white matter. So it's a function of the white matter in preterm, which leads to white matter necrosis, which is followed by cavitation and cyst formation. It's more common in premature neonates. Those are less than 34 weeks with a median age of 30 weeks and less than 1.5 kgs at birth. So here we're seeing a case of periventricular leukomalacia, and it's progression, ultrasound A and C at the initial, and BD now the progression to the periventricular leukomalacia. So in first, we're just seeing the first sonogram, we're just seeing areas of increased echogenicity. That is around the ventricles, and also this area is also a bit in the parasagittal. We're seeing an area of increased echogenicity, and after a while,
So
the
that
patient
increase in echogenicity is where? It's in the periventricular
around,
white matter. So it's a white matter
yes,
increased echogenicity. And
yes.
normally in the first week of life, the white matter has it's echogenic. It's called the white matter flare. But if it persists for more than 1 week, then you would suspect it was white matter injury. Usually they tend to have some form of asphyxia or some issue like that. So even babies who suffer birth asphyxia tend to have similar findings. Sometimes you might have now some infarction, like in that corona. It looks like it's extending to the thalama, yeah? Yeah.
Yeah,
But maybe it was
same.
just the way the cut is. It's probably just all within the white matter of the temporal lobes. Yeah, could be temporal lobe. It's a bit anterior.
So
Yeah, it's not in thalama. It's more anterior. Okay, that's fine. We can proceed.
Yeah, so we have two types which you've already seen, cystic and non-cystic. So the cystic, you have the formation of the cysts, mostly at the arterial border zones at the level of the optic radiation next to the trigones, and also the frontal cerebral white matter near the foramen of Monroe. In the non-cystic, it will be the diffuse cerebral cortex white matter damage, and you will have microscopic focal white matter changes around the basal ganglia, the thalami, and cerebral damage. Yeah. So the white matter can also be thinned. This will be later with the irregular ventricular wall, and also the corpus callosum will become injured, and it will be echogenic, and with time also in some patients it will also be thin. So the radiological features, I think we have already said, alluded to it. At around 2 weeks, the periventricular white matter will be will have increased echogenicity will be greater than the adjacent choroid plexus. At around 4 weeks, you might have cystic changes which may develop in the area of that was echogenic. The cyst may be single or multiple, and they're parallel. They are parallel to the ventricular border and deep in the white matter. The cysts can measure from millimeters to up about 2 centimeters. They're usually bilateral and often symmetrical. We already said that there will be cystic changes within the corpus callosum, which can also lead to thinning. Yeah, and in subsequent sonograms, the lesions may either enlarge or resolve. So there were 2 grading systems that I found. I'm not so sure which one. I think the lower one is one that's being used more, but there was one with
the
done
lower
by Leisure. Yeah. Yeah, so let me just go through the lower one, we do the correct one. So for grade 1, there's areas of increased periventricular echogenicity without any cyst formation persisting for more than 7 days. In grade 2, the echogenicity has resolved into small periventricular cysts, and in grade 3, the areas of increased periventricular echogenicity that now the cysts become larger. Let's just say it becomes extensive in the occipital and the frontoparietal region. And then in grade 4, the areas of increased periventricular echogenicity in the deep white matter developing into extensive subcortical cysts. So we'll go through the grades. Here we have grade 1. And we're seeing there's an increased periventricular echogenicity. We are not seeing cysts within the white matter this time, so that's why we're saying grade 1, and it is done more than 7 days. So that fits into the grade 1 cyst. And here we're saying that it is, that's what we're saying. That it is coarse, it has a bit of a coarse echo texture. And then in grade 2, you have a small periventricular cysts that are shown by the yellow arrows. There's around anechoic lesions, and they're bilateral.
The coarse echo texture could be more to do with the image quality, the kind of machine. It's a bit of a noisy machine. It doesn't have that thickening software, the image. Yeah.
Oh, okay.
Remember, there's some image you had shown us before, again, grade 1, but it was not this course.
Oh, yes. The first
so it's more to do with the machine,
machine itself. Okay.
The image quality.
Okay. Thank you. So here we have grade 2. We have the small periventricular cysts. At this time, the echogenicity had resolved, but we had the cysts that are visible there. That's in grade 2. And then in grade 3, we said now the cysts become larger. So there's increased echogenicity and the development of the periventricular cyst now in the occipital and the frontoparietal region. And then grade 4, we said we have now subcortical cysts also, which are now visible in this grade 4 image, which are there. So now this is grade 4 of periventricular leukomalacia. I think Doc had already mentioned this. Flaring is when the white matter appears echogenic, that is in less than 7 days. So you will need a follow-up ultrasound to confirm if the echogenicity has persisted or you have cyst formation. Then that's when you will start grading your leukomalacia. So here again is just to show the difference. Now here we have the coronal and the parasagittal images, which we are seeing flaring. Here, sorry, not flaring. Yeah, flaring. We're seeing the increased echogenicity, periventricular echogenicity at the occipital, and we have here the nodes there. But on repeat, when
you compare that, you compare the echogenicity with the choroid plexus.
Yeah.
It should be same or more for you to call it.
So now these were follow-up scans, and now there's normal white matter. So this was just a case of flaring. Okay, so we go through the clinical history. There's very low birth rates, premature infant, and mechanical ventilation for around 34 days. The patient had high oxygen needs, had episodes of cyanosis and electrical disturbances, had spasticity, and left facial nerve palsy at 4 months. The baby was born at 920 grams and at 27 weeks by CS, and was the second twin. It was taken to Nico. So we have scans at 1 week, 1 month, 2 months, and 3 months with that ultrasound transducer stated there. So the image quality again is it's not so good, but this was image at 1 week, and we're seeing there's echogenicity around the lateral ventricle on the left. So that area of echogenicity in the coronal plane. And then we have still the periventricular echogenicity that was visible bilaterally. This was still at 1 week. Follow-up scan at 3 weeks, although it's not very clear. I don't know if you can see it very clearly, but here we're seeing cysts bilaterally forming at the frontal bone. This is at the level of C5. So we're seeing cysts, periventricular cysts.
Those cysts are forming where?
Oh, okay. No, this is at the
This is
level
a coronal,
of the
remember?
coronal, yes.
Trigon.
Oh, yeah,
So
the
it's a
trigon.
trigon, right?
Yeah, yes. Yes, so we have at the trigon area, we have now the periventricular cysts there. And then this ultrasound was at 2 months. So there were variable sizes of the cysts that are visible around the white matter. This was I think it was a sagittal, parasagittal plane. And then at 3 months, there was distortion of the contour of the lateral ventricle with incorporation of the necrotic cyst. So this is a case of parencephaly, as we had earlier said. Yeah, because you're seeing that there's a difference between the size and the shape of the lateral ventricles. All right.
Yeah, but both of them are abnormal.
Oh, okay.
These are bilateral. Huh?
Yes. Okay. So on MRI, it is the best method of diagnosing the PVL. In MRI, the use of DWI, which shows hyperintense areas of restricted diffusion, have shown that the white matter damage to premature infants extends to the beyond periventricular areas to the cortex, thalami, basal ganglia, brainstem, and the cerebellum. In T1 weighted MRIs, it shows low signal intensity in the early stages. In T2, we have high signal intensity in the periventricular region, and diffusion images, as we had said, are more sensitive because there will be high signal because there's restricted motion, and ADCs will have a low signal. MR spectroscopy will show high levels of lactate because there's now breakdown of the brain matter. So we have again the two MRI grading systems. Again, I wasn't so sure which one is being used for this one, but there's one for Sai et al. And Murgo et al.
Yeah, just go through both of them since we have rarely done this. And this must be much more because we rarely do MRI for those for the babies anyway. But there are newborn units out there who have portable CTs and portable MRIs. Can actually have a portable MRI, a small enough MR. Yeah. So let's see what they say.
All right, for societal, the grade 1 shows a normal MRI. For grade 2, there's altered periventricular intensity. Grade 3, there are fewer than 6 punctate hemorrhages in the white matter. And then for grade 4, there's multiple punctate hemorrhages, a few large focal hemorrhages, and or small periventricular cysts. In grade 5, 5, there's extensive signal intensity changes within the hemorrhagic and or cystic lesions in the white matter with minimal focal extension into the subcortical region. In grade 6, there's diffuse signal intensity changes within hemorrhagic and or the cystic lesions in the white matter and the subcortical region. And for Mugo et al., they did a combination of both ultrasonographic and MRI grading system, and they have 3 grades. Grade 1 is periventricular hyperechogenicity for more than 1 week with MRI is negative for PVL. And then grade 2, a periventricular hemorrhage and or decreased white matter on MRIs, and grade 3 is if you have cysts. Yeah, so those are the 2 grading systems I came across.
I think CS sounds more specific.
Yes.
MRI.
Yeah.
Yeah.
Yeah. So this would
summarized.
Yeah.
Even 2 summaries for ultrasound.
This one, yeah. Yes. So we'll go through images again. We have a 31-week gestation infant. This was done at 4 weeks. We have the coronal and a parasagittal view. Again, we have cysts that are visible around this area. That is an A, and B, we have the cysts in the frontal and part of the parieto-occipital loop that is there. And then on image C, this was a T2 weight.
So that grade would be what?
Sorry?
A and B would be a grade. A and B would be a grade 2.
2, yeah.
A grade 2 PVL, isn't it?
Yes, yeah. Yes, because they're small cysts. Yeah. And then C was a T2 weighted MRI, again done at 4 weeks, and showed also the extensive cysts there, that are visible in that area. And then I think this was a later one, at T1. I don't know what TEA means, but there were high signal intensity changes with white matter loss that are more marked on the right than the left. Yeah. So we'll go through some.
Seen by the ventriculomegaly.
Oh, yes.
You can see the white matter loss is more because you can see the ventriculomegaly. Yes.
Oh, okay. Thank you. So term infants with hypoxic ischemic encephalopathy. So you have diffuse cerebral edema with or without subarachnoid hemorrhage, which is a common result of hypoxic ischemic events in a full-term infant. So for cerebral edema in an ultrasound, you will see effacement of the South-Zen gyri, and the ventricles will appear slit-like. You won't be able to visualize them that well. Yeah, and the brain parenchyma is also echogenic. So here we have sonograms. Here we have at the frontal lobe. This one would be at around the C1 cut, and we're seeing there's effacement of the South-Zen gyri. You can't really see them in this area. And then as we move towards the body, the frontal horns of the lateral ventricle, they appear very slit-like, barely visible at that area, and also the salsa is effaced and echogenic. In the parasagittal views in C and D, you can also see that there's the white matter is echogenic. You cannot visualize the lateral ventricle as well as in a normal infant. Yeah, so they would present more with features of cerebral edema. Yeah. Yes. So I think maybe the pattern of injury, I'll leave this so that you can read at a later time in term newborns, so that you can go through the MRE features. So this case was of a term newborn with an APGAR of 2 up to 15 minutes. So there was severe birth asphyxia.